Yeah, I'm assuming that I am audible, and we are starting with our ultrasound in female infertility. So when we define infertility, it is inability to conceive after 1 year of unprotected sexual intercourse in women under the age of 35 and 6 months of unprotected intercourse in women older than 35. This definition actually holds very true when practically we are looking at the patients day to day. Worldwide, the infertility incidence varies, however, it is approximately 15.5%, which is huge enough for us to understand the importance of imaging in infertility. Although the etiologies, the causes remain unexplained in 28%, but we do have correctable causes and interventions where assisted reproductive techniques come handy and our imaging plays an important role. Defects in ovulation, male factor, tubal factors in female are some of the common ones. There is a basic workup for infertility, whereas in the females, where we check ovarian reserve, tubal and uterine assessment, thyroid issues, prolactin disorders, PCOS, which is the most commonly misdiagnosed and overdiagnosed condition in females, and then comes the male factors. Today, we will be covering the female workup for infertility. There are different types of ultrasound scanning for infertility that we do. There is a baseline or screening ultrasound in which we assess the pelvic anatomy. In this, we are going to look at the uterus, its lining, bilateral ovaries, adnexa, the cornual area, broad ligament, the tubal factors, hydrosalpinx, ovarian cysts, uterine malformations, congenital malformations, acquired malformations, all of that we check in the baseline screening ultrasound. This scan we usually prefer between second to fourth day of the periods because that is when it is considered as the baseline. If there are follicular cysts, they resolve. If there are hemorrhagic cysts, they shrink down. So we have a baseline screening for the pelvic organs. Then we have follicular monitoring ultrasounds. They are used to track follicles that are maturing and measure the endometrial thickness and the endometrial consistency. Saline infusion sonograms, whether we do with 3D or without, they are used to assess uterine cavity for any abnormalities and for tubal patency. It is painless when it comes to HSG versus SIS. Abdominal ultrasound may be required in addition to these above for better evaluation of overall structures. For example, if we have serosal myomas or broad ligament myomas, and you are assessing the patient for the first time, it is suggested that you do a full abdomen ultrasound with full urinary bladder and then take it forward from there, passing of the urine and doing an internal ultrasound, a transvaginal scan. Also, in situations where transvaginal ultrasound is not possible, you can always consider doing a transrectal ultrasound. If there is vaginismus or the female is not sexually active, in such cases, we can always have an option of transrectal ultrasound. The transabdominal ultrasound and transvaginal, the basic frequencies we have done in previous lectures also, that for transabdominal, we need 3.5 megahertz or higher, whereas the scans performed via the vagina, the transvaginal or the transrectal, should use frequencies of 5 megahertz or higher. We have in our department 7.5 megahertz. The indications for transvaginal sonogram. There is a baseline assessment of the uterus, ovaries, adnexa, to rule out any pathology like fibroids, polyps, uterine anomalies, hydrosalpinx, or PCOS. This is what a baseline assessment we have to do is that looking at the basic anatomy and the adjoining structures. Also in transvaginal sonogram, we look at the ovarian reserve assessment, which is also known as antral follicle count. Get back to the indications of transvaginal sonogram. After the ovarian reserve, the antral follicle count, we have monitoring of the ovulation induction, During clomiphene citrate, letrozole, usually we give letroz to the patients. Whatever we are planning, whenever we have to induce ovulation for IUI or IVF, the monitoring through the transvaginal ultrasound is very important. Try and convince the patient and explain it to them the importance of transvaginal, the specificity and the sensitivity versus transabdominal. Some patients do get apprehensive of doing repetitive transvaginal ultrasounds. Never compromise. Try to explain it to the patient, show them the difference that when you are doing transabdominal, the size measurement is not as accurate as when you are doing a transvaginal sonogram. For IVF, IUI cycles, we have to be very careful with the size of the mature follicle. We have to induce ovulation according to that. So the size is very important. We will also show you how to measure the follicle size. For timing the ovulation trigger, we do need the size again, and we have to do a transvaginal scan. When you are implanting, when you have taken out the egg retrieval has happened, the embryos have formed, now is the time for the transfer. At that time, we need the endometrial thickness. I always explain it to my patients that we have a seed, which is the embryo, and we have a soil, which is the endometrial lining. Both have to be in sync when it comes to a successful IVF or a successful IUI. You have to prepare the seed, and then you have to also side by side prepare the soil. The soil is our endometrial thickness, the morphology, consistency, its peristalsis, its vascularity, each and everything is very important, which has to be assessed with the transvaginal ultrasound. For performing oocyte retrievals and sometimes for embryo transfer and other procedures, it is done under guidance, transvaginal. For transabdominal sonogram, when the uterus is large or there is previous history of any surgery when the uterus is pulled up or there is adenomyosis, in such conditions, transabdominal ultrasound comes in handy. When the uterus or ovaries are closely adhered to the anterior abdominal wall, secondary to scarring, we do have transabdominal ultrasound as our complement. Saline infusion sonogram is not used in day-to-day cases, but only in selected cases. This is to assess the uterine cavity for polyps, for submucosal fibroids, intrauterine adhesions, scarring, and uterine malformations. If the patient is unable to take the pain and you are not able to give any sort of, the radiation is contraindicated and HSG cannot be done the traditional way, then saline infusion sonogram is definitely an option. However, there are contraindications when we do not prefer doing SIS. If the patient is having heavy periods, if there is any sort of infection suspected, or when you are about to examine the patient and you see that there is vaginal discharge, and of course in pregnancy, we do not do saline infusion sonogram. However, to do it, you should know that the patient will lie down in dorsal lithotomy position in the same ultrasound room. We will do it through the transvaginal probe. There is a bi-valved speculum which is available for SIS, which is placed in the vagina. The cervix is cleansed and the catheter is induced. When tubal patency has to be checked, if you just want to check the polyp, then you will induce 2 ml of fluid and you will see that the cavity is distended and you can assess it. However, if you want to assess the tubal patency, then it is preferred to use the catheter that has a balloon in it, and we wedge that between the lower uterine segment to block the backflow, and we agitate the fluid so that bubbles are created. After the catheter is placed, the speculum is removed and the probe is inserted. Normal saline is introduced through the catheter and you are doing the ultrasound side by side. This will distend the cavity, and when you agitate it, when you agitate the fluid, some air bubbles are created, and then that you induce to see the tubal patency. This is how you are going to see the cavity which is distended with normal fluid in SIS, saline infusion sonogram. Now, if there are adhesions, if there is a polyp, if there is a myoma, you will be able to see that better as compared to a cavity which is not distended. It is easily available. One can do it. This is hysterosalpingo contrast sonography. If you are using ultrasound contrast, then you can also introduce that contrast, a mixture of air and normal saline. Usually how we do, we add air and normal saline and mix it up, shake it up a bit so that small air bubbles are created. Otherwise, if you do have contrast, you can use the sonography contrast. And the same way as we see in HSG, we see the tubule patency. After everything is done, you will deflate the balloon, remove it, and the catheter is removed under ultrasound guidance. This is how the uterine cavity looks like. The important part is that you should be able to understand how air will look in the cavity. They are echogenic, hyperechoic. They become white. And when they become white, you should know that they give dirty shadowing posteriorly. We know it's air. So we'll be able to see air on both sides when the tubes are patent. Getting back to our baseline assessment, which we do in every case of female infertility evaluation. This baseline assessment using transvaginal ultrasound and with complement of transabdominal ultrasound for conditions which we have discussed before. If the uterus is bulky, if it is adenomyosis, if it is adherent to anterior abdominal wall due to prior surgery, it's pulled up. In such cases, we do. In this, the assessment remains the same. We have to assess uterus, endometrium, ovaries, adnexa, and cul-de-sac. Always keep this in front of you when you are starting to do infertility imaging. Many times we look at the uterus and endometrium and ovaries. We forget about the adnexa and cul-de-sac. What to see and how? Let's start. The uterus is evaluated both in sagittal and transverse plane. We have to evaluate the size, shape, and orientation of the cervix, uterus, myometrium, endometrium. The length and height of the uterus is measured in sagittal plane and width in transverse plane. At the level of tubal cornea, basically corneal level, we will show you how. The myometrium is evaluated for fibroids, adenomyosis, and if they are present, then we have to give 2 dimensions and measure the location and character of the lesion. Measuring of the uterus is very important. If it is asked if the uterus is suspected to be small in size, or there are recurrent miscarriages, and the uterus subjectively, when we are doing a transvaginal ultrasound, it looks smaller, then it is important to give the total length of the uterus, which means from the fundus to the starting of the point of the cavity, from the cavity till the uterocervical junction and the cervix. So A plus B plus C will give you the total length of the uterus. However, when we are doing day-to-day, we do not take these 3 measurements and we check from fundus to cervix and we check one length, which is longitudinal length, and we take antero-posterior length. And these 2 lengths are taken in the sagittal view, whereas when we rotate the probe 90 degrees, we get the transverse and we take the transverse length, the width of the uterus. These 3 measurements should be given, and this, if you take out the volume, that is even better, because in cases where you have fibroid, if the uterus is more than 250 or 300 cc, then we have to consider getting an MRI for the better evaluation of the uterus. So it is important that these 3 measurements and the volume is taken in every case. This is how practically we take. This is the length, the antero-posterior diameter, and the transverse diameter that we take. After the size, we are going to look at the endometrium. 3 things that we have to see in the endometrium are its thickness, vascularity, and morphology. The thickness of the endometrium, initially when the periods just end day 2nd to day 4th, whenever you are starting infertility imaging, always start from day 2nd of the period. So tell the patient that between days 2nd, 3rd, and 4th will be your baseline imaging. In that baseline imaging, when you look at the endometrium, it will be around 4 plus minus 0.2 millimeters, and it increases to 10 plus minus 0.3 millimeters just before ovulation. The mean remains about 10 to 12.5 before ovulation. The endometrium is measured perpendicularly from one echogenic border to the other. So if you look at this, this is the endometrial lining. We are going to measure the thickest part, the outer echogenic part, from one side to the other. In the mid-sagittal plane, it is important that you measure it at the thickest part and also that it is in the true sagittal plane. You should be able to see the entire uterine cavity before you give your measurement of the endometrial thickness. The endometrium changes throughout the menstrual cycle. Now just have a look at it and have this as your picture memory, that when you get periods, shortly after menstruation, it is going to be thin, 4 mm. In the proliferative phase before the ovulation, it becomes triple layer. Later in the proliferative phase, just before ovulation, it becomes even thicker and triple layer. And secretory phase, it will become homogeneously echogenic. So this is how the endometrium normally changes in the menstrual cycle. The endometrial morphology can be categorized into 3 patterns. It is trilaminar, which is a triple layer endometrium, as we saw in the proliferative phase. It is homogeneous, as we saw in the secretory phase, and it is heterogeneous, in which there are polyps, in which there are myomas or adhesions. A trilaminar endometrium is triple layer characterized by hypoechoic endometrium with a central line. This pattern is noticed during the follicular phase from day 5 to 6 before ovulation and continues till the day of ovulation. So if you go back to the image, this is how it's going to look from day 5 or 6 of the periods till just before ovulation. So the day you are checking for ovulation, the endometrium will look a triple layer thickened endometrium, which is smooth otherwise. And the presence of trilaminar endometrium on the day of the trigger is associated with higher pregnancy rates. So it is important to understand that the day the follicle is 18 millimeters and above, which is the mature follicle for us to give a trigger injection, the endometrium should be like this. The thickness should be about more than 10 mm. Up to, even if it is 9, it is good enough. But less than 8, we do not consider it good as a good soil for the seed. So this is how it should look like the day you are going to give trigger, because that is associated with higher pregnancy rates in IVF. The first half of the menstrual cycle, the endometrium is in the proliferative phase, measures 4 to 8 millimeters. This is a normal endometrium in the periovulatory phase. The endometrium here measures 9 mm. This is trilaminar appearance. The central functional layer, this is the hypoechoic central functional layer, the echogenic outside 2 layers and the central hypoechoic layer. This is the functional layer of the endometrium. Periovulation time, the central functional layer is relatively hypoechoic. So it gives a trilaminar appearance with 3 echogenic layers formed by 2 basal layers of the echogenic endometrium. These are the 2 basal layers of the echogenic endometrium. One is this layer, one is this layer. These 2 are the hyperechoic endometrium, and the cavity is collapsed. This is the cavity, which is the central echogenic collapsed endometrial cavity. So we have got 3 echogenic layers, and in between we have got the hypoechoic functional layer. So this appearance trilaminar is very important when you are giving trigger for the IVF injection. In the later half of the menstrual cycle, after ovulation, the endometrium is in the secretory phase and is uniformly echogenic, measuring up to 14 millimeters, because now the cells are rich in glycogen and mucus. So the triple layer changes into uniform hyperechoic or echogenic endometrium. This shows endometrium 15 millimeters. It is echogenic due to mucus and glycogen in the endometrial cells. The endometrial vascularity is also very important. It has to be classified into 3 grades based on the visual assessment of the endometrium. Grade 1 shows that there is no subendometrial flow or very minimal subendometrial flow is there. In grade 2, the subendometrial flow is significant. In grade 3, there are both endometrial and subendometrial flow. The 3 grades are given usually. However, according to the International Endometrial Tumor Analysis Group consensus statement, 4 color scores are defined. It depends what you are using and what is your better outcome with the assessment, depending on the machine that you are using, the color Doppler that you are using, the level of the precision that you have. We in our department use 4 color scores. How do they look? The color score 1 is that you cannot see even a single speck of blood, or maybe there is one here, one there, just a little. But you are not able to see. We label it as color score 1, which means no color. In color score 2, we have mild in the subendometrial region. We have mild color flow. In 3, it is moderate. You can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 specks of color inside. And in 4, it is abundant. This color scoring is important not only for the triple layer endometrium, but also for RPOCs, for assessment of vascularity within the cavity, for assessment of the endometrial vascularity. This color score is very easy to understand, and when you are doing the ultrasound, it becomes easier even. You have to make sure that the PRF is kept at a certain point and the velocity is at a certain point. 0.3 to 0.6 kilohertz and 3 to 6 centimeter per second velocity scale will make sure that you have the color score without artifacts. Now, while you are assessing for infertility, you have to make sure that you rule out endometrial synecdoche or adhesions. These are very commonly seen and quite often missed. They represent adhesions and fibrosis in the canal that can be due to the result of DNC, cesarean, intrauterine device placement, or simply pelvic infections which are not even noticed. In this, SIS plays a significant role. However, if you see that the endometrial lining is heterogeneous and there are or suspected adhesions, then call the patient while the patient is on her periods. Due to the menstrual blood, we can see, apart from the clots, we can see fixed adhesions inside. The clots will move, the adhesions are flimsy, they just move from one point, but they are attached to the cavity from the other point. So if they are present, then we have to consider hysteroscopy and surgically remove it to improve fertility. This is a 28-year-old woman with recurrent pregnancy loss, transvaginal hysterosonogram. If the fluid is not there in the cavity, then you do SIS and introduce the saline. You see multiple echogenic linear bands of fibrosis. Then hysteroscopy was done and the lesions were removed. So these are adhesions that you see. They appear echogenic, they appear linear and thin strands. So this is how it is important to have every knowledge of your ultrasound, that how important is SIS. Now, when you have not introduced fluid, how do you suspect? See, the endometrium is very irregular. You can see previous cesarean scar. You know that there is a cesarean scar. You know that this is heterogeneous. And during her periods, due to this little menstrual flow, we can see that there are adhesions inside, which are not moving. They are as it is. So they are not blood clots, but they are adhesions. So intrauterine adhesions suspected, advise hysteroscopy or SIS. Apart from the evaluation of the uterus, the endometrium, myometrium, now we are shifting to the ovary. Based on the stages of development, the ovaries have primordial follicles, primary, secondary, tertiary follicles, or antral follicles. The number of primordial follicles determine the true ovarian reserve. They are small, they are very difficult to be seen on the ultrasound. What we see are the antral follicles and we give a count of that. But actually, whatever we are seeing on the ultrasound, the primordial follicles are more than that. They are 6 to 7 million at the age at around 5 months of gestational age. And at menopause, they go down to 1000. So when you are telling your patient that the follicles are 8, 9, 10, you have to explain it to them that you are looking at the antral follicles and this is the antral follicle count. This is not the primordial follicle. So this is important to make them understand. The antral follicle count is one of the standard measurements of ovarian reserve and is calculated as the sum of all follicles ranging from 2 to 10 millimeters in both the ovaries. Any follicle which is more than 2 will be seen on ultrasound clearly, so we count that, and up to 10 millimeters. The preferred time is during day 2nd to day 4th of the periods, because during that time we do not have ovarian cysts, there is no corpus luteal cyst, so the ovaries are at a baseline. Even though there is slight variation in the antral follicle count during menstrual cycle, this can be performed at any time, as long as cysts are not obscuring the view of the follicle. A cyst will cause mass effect and will obscure the follicles because they will be effaced then. So that is the reason why if the ovaries have multiple cysts, we should not give an antral follicle count, or we should mention in the report that due to the presence of the cysts, we can only visualize 3 or 4 follicles. Therefore, the antral follicle count has to be reassessed after the resolution of the ovarian cysts. What is the role of AFC? It has a similar accuracy as anti-Mullerian hormone levels in predicting the ovarian reserve. So we often give AFC along with the serum anti-Mullerian hormone assessment, and AFC less than 5 is considered low. That is a collective from both the ovaries. That means from one ovary you measure the follicles, say there are 2 or 3 follicles seen, from the other ovary 2 and 3, so our count is less than 5 together. That means one ovary, right ovary plus left ovary. If it is less than 5, it is considered low. AFC more than or equal to 20 is associated with a high ovarian response. And in such cases, you have to be careful not to overstimulate the ovaries and result in OHSS, which is ovarian hyperstimulation syndrome. Therefore, AFC can be used to adjust the gonadotropin dosage. If it is less than or equal to 4, then we have an increased risk of menopause in next 5 to 7 years. So this is the importance of antral follicle count that we see from the perspective of IVF and infertility. We are looking at the ovaries. How are the follicles looking at? If you look at the image over here, it shows 10 follicles, whereas here it shows 2 follicles. The stroma is echogenic. The follicles are less. Antral follicle count less than 4. This is the image that we have in our setup when we are doing antral follicle count, that how to respond. How will FSH, what will be the response of IVF? How will be the anticipated pregnancy rate? If the antral follicle count is less than 4, we say that it is very low antral follicle count. The response to FSH will be poor, and there is cancellation of IVF most likely. Anticipated rate with IVF pregnancy will be less. If the antral follicle count is 4 to 6, our interpretation again is that it is low, the expected response is poor. If it is 7 to 10, it is reduced antral follicle count. However, we know that the chances are less, but still they are there. The antral follicle count between 11 to 30, it is a normal antral follicle count. And if the antral follicle count is over 30, we know we are heading towards PCOS. So the risk of OHSS, the ovarian hyperstimulation syndrome, is high. So we have to be careful with our antral follicle count and very precise in giving it, because it does carry an importance, and the normal antral follicle count is 11 to 30. So you should know the normal. You should know what happens if it is high, what happens when it is low and very low. FSH receptors are developed in the antral follicle once it reaches a minimum diameter of 6 and further growth is under the control of FSH. That is why the importance of giving the antral follicle count along with the blood work that carries the FSH. Dominant follicles are considered when they are over 10 mm. By day 8 to 12, dominant follicles are usually formed. Follicles grow at an average of 1 to 1.4 per day until they reach 20 to 24 at the time of ovulation in a natural cycle. So you should expect, when will you call the patient when you are doing an ovulation scan if the follicle is 12 and you want to give the trigger at 18? Obviously, you will not call the patient the next day because you know the follicle is going to maximum from 12 become 13.5 because maximum is 1.4 or 1.5 rise in one day. So you know you will call the patient after 2 days. So this is the importance of knowing the average growth of the follicle. For ovulation trigger, we usually use a cutoff of 18 to 20 before egg retrievals. This differs for patients undergoing different treatments. Once the ovulation happens, the follicle collapses and a luteal cyst is formed, giving ring of fire. Important part is that how are you going to measure the follicle? The follicle has to be measured in 2 dimensions. If it is a regular sized follicle, a regular shaped follicle, you will take 2 measurements and you will do the average of that. So if this is 20 and this is 10, your average will be 20 plus 10 divided by 2. You will not give 2 measurements and leave it. You will not give 1 measurement and leave it. You will take 2 measurements. If this follicle is irregular shaped, then you can take 3 measurements and give a volume also. So it is very important to understand that we always give the average and not a single measurement. According to single measurement in this image, this is 24. That means it is way beyond our trigger also. But if you take the average, then it turns out to be 20. Because this measurement is 24, this measurement is 24, and this is 17. So average is coming out to be 20. That means it is good for us to get the trigger. After the ovulation, the follicle becomes luteal cyst and there is ring of fire around it. So we know that this has ovulated. Most important when you are doing infertility imaging, you have to talk about PCOS. And you have to explain it to the patient. Even if the patient says, I have been PCOD patient for last 5 years, I am on medication, you have to assess from the beginning if you are seeing the patient for the first time. We still consider Rotterdam criteria, in which we have 3 things. Number 1 is the biochemical tests. That means what the chemical composition of the hormones are. Number 2, what are the symptoms of the patient? Number 3, how the ultrasound appearance is. Out of this, if 2 are present out of these 3 criteria, we consider it as PCOS. So what are those 3 criteria when we are looking at, what are the criteria when we are looking at the ultrasound? On the ultrasound report, never mention PCOS. You don't know whether it is a syndrome or not. What you see on ultrasound is the morphology. Like I always explain, not every fat person is sick or is having ill health, and not every thin person is healthy. So the morphology, the look and appearance does not define the health status. Similarly, with the ovaries, the morphology alone is not good enough to make you label the person as PCOS. What we give on ultrasound is morphology. Then it has to be complemented with other imaging. It has to be the supplemental blood work has to be done and clinical correlation. Then out of those 3 criteria, if 2 are present, then yes, we say that this is PCOS and we have to treat it accordingly. The Rotterdam ultrasound polycystic ovaries are when there are more than 12 follicles, 12 or more than 12 follicles, and or the ovarian volume is more than 10 in at least one of the ovaries. So if the follicles are more than 12 and the size is less than 10 mm and the volume of the ovary is more than 10 cc and there are no dominant cysts, then we consider that as a criteria. The specific cutoffs, the diagnostic cutoffs have been debated quite a bit, but we consider more than 20 follicles as considering it or more than 25 as considering it abnormal. String of pearls appearance, peripheral location of the follicles are all supportive features. Echogenic central stroma. If you are lucky enough, you can see that. And if there is peripheral location of the follicles, if the central echogenic stroma is there, the volume is going to be more than 10 cc because it is a bigger ovary. The follicles are going to be more than 12. So all these things come together. Looking at this, the volume is more than. So how do you take the volume now? When you are assessing the ovary, you will take the sagittal view, take a longitudinal image, take a longitudinal measurement and an anteroposterior. Then you rotate the probe and take a transverse. This is the transverse view and the transverse width of the ovary. So we take one measurement, second measurement, and third measurement like we did in case of uterus. The same way we are going to assess the volume of the ovary. Multiple follicles consistent with polycystic ovarian morphology again. This is how normal ovary looks like. These are maturing follicles. This is the normal follicles, normal this. And these are the polycystic follicles. Remember, in polycystic, there are no dominant follicles. So it is important, and you have to also explain to the patient that polycystic does not mean there are cysts inside. These are rudimentary follicles which form the polycystic ovary, and the stroma is echogenic. Next, hyperstimulated ovaries. Now, if you have PCOD patient or PCOS patient or PCOM patient, if the morphology is also there, and the antral follicle count is over 30, now what do? You are giving the stimulation to the ovaries. You have to be careful because such ovaries can undergo hyperstimulation and result in a complication. Enlarged ovaries more than 10 centimeter. So if you take the longitudinal measurement, it will be more than 10 centimeter. There will be fluid around it and also fluid in the Morrison's pouch by the transabdominal ultrasound. This is liver, ascites, right kidney. This is the enlarged ovary. More than 10 centimeter one length is good enough and multiple cyst for us to label it as OHSS. Bilaterally symmetrical enlarged ovaries containing multiple varied size cystic lesions representing enlarged follicles or luteal cysts giving wheel spoke appearance. We will show you that. Acute fluid shift out of the intravascular space resulting in ascites. We will see fluid in the Morrison's pouch, in the pouch of Douglas, etc. When do we say it is mild, moderate, and when does it become severe? If there is abdominal distension, nausea, vomiting, diarrhea clinically, and the ovarian size is still less than 6 centimeters, we say that it is mild. If the ovarian size becomes more than 6 centimeters, but less than 12, and there is ascites also on ultrasound, and the patient has gained weight, there is abdominal distension, nausea, vomiting coming with that, this is considered as grade 3 or moderate. In severe cases, it is the size of the ovary, the length is more than 12 centimeters. There is ascites, and now the fluid has also gone into the lungs. Along with that, if the patient is going in a state of renal shock, then the grade becomes 5. So this is OHSS in case there is a complication and you have to monitor it. After the ovaries, we have the adnexa to be checked. Very important, often missed when we are doing a transvaginal ultrasound or assessing the female for infertility. We have to look at the tubes, we have to look at the paratubal cyst and the para-ovarian cyst. In this image, we can see that the ovary is seen separately. These are the bowel loops. This is a cyst. So it becomes a para-ovarian cyst. This is adnexal mass, very complex. Ovary not seen separately, tubo-ovarian mass. So this is the hydrosalpinx got complicated, forming a pyosalpinx. Hydrosalpinx, how do you assess? It's a tubular structure that has got appearance elongated. We have to give the length as well as the AP dimension. Different types, how it looks like. There are some signs that we talk about when we are talking about hydrosalpinx, you should be able to see the uterus separately, bowel loop separate, ovary separate. Then you can label this as para-ovarian cystic structure, tubular cystic structure, showing aperistylitic movements. There are no movements seen, it is fixed. And it has got thin partial septae within and no vascularity on color Doppler. So this is hydrosalpinx. Two appearances we give, one is waist sign and one is cogwheel appearance. The cogwheel appearance is these small echogenic foci that you see inside the structure. Now this is the cross section of fallopian tube, which is showing hydrosalpinx with cogwheel appearance. These things indicate that it is a result of pelvic inflammatory disease. If there are internal echoes in the tube fluid, then we call it pyosalpinx. Thick-walled tubular structure filled with complex fluid. Differential diagnosis will be hydrosalpinx and pyosalpinx. If the fluid is clear, hydrosalpinx. If the walls are irregular, giving cogwheel appearance, think about PID and pyosalpinx. These are the endosalpingeal folds surrounding the tubal thickening and acute tubal inflammation. Patient will also be presenting with pain. So we know it is pyosalpinx and we have to treat it accordingly with antibiotics. There is a waist sign. Many times when you are doing the ultrasound, you tend to get lost whether this is part of the bowel, whether this is ovary separately, and whether this is fluid. Many times you will not be able to define the walls of the tube because they are very thin. If you see that there is a little constriction and narrowing and then the ovary is seen, this narrowing is known as waist sign. It looks like a waist. So this is waist sign. So we know that the tube is dilated. And this is hydrosalpinx. This is a 45-year-old patient presenting with chronic pelvic pain. Bilateral hydrosalpinx we can see that this is the ovary, waist sign, and the dilated tube is surrounding the ovary. This is the ovary again, the tube surrounding, and this is forming the complex because as you can see, the ovary is not free to move. So it is forming the tubo-ovarian complex on the right side. And we can see the left hydrosalpinx. Para-ovarian cysts can also be seen when you are doing transabdominal ultrasound. They arise in the broad ligament. They comprise 10% of cystic masses, adnexal cystic masses. Although they are mostly clear cysts that you see, but they can also they can also cause bleeding, infection. To be diagnosed as para-ovarian tissue, a para-ovarian cyst, a tissue plane between the cyst and the ovary must exist. Let me show you in the first image that we saw, going back to that what is this? How do we say that this is para-ovarian? It is not connected. Look at this image. This is the normalcy which is seen between the ovary and the cyst. So this becomes para-ovarian. A tube will always be connected to the ovary, either through a thin linear band or something. It will be adjacent. When there is normal structure in between, then we call it para-ovarian cyst. So that is how you differentiate between tubal and para-ovarian cyst, that a tissue plane must be present between the cyst and the normal ovary. After the adnexa, we have to evaluate the cul-de-sac. Most important in infertility because of the presence of adhesions in cases of endometriosis, adenomyosis, prior surgeries. The transvaginal probe is placed near the posterior vaginal fornix to assess whether the cervix and uterus glide over the anterior rectum and sigmoid colon. And if there is no free gliding or sliding seen, we say that the sliding sign is absent and adhesions are suspected in cul-de-sac. How do we assess the uterine sliding sign? The transvaginal ultrasound probe is introduced into the posterior vaginal fornix, then withdrawn to see the movement of the rectum against the posterior vaginal fornix and the posterior uterine wall. You can apply slight pressure from the other hand on the uterus. If the sign is positive, That means the sliding of rectum against the posterior uterine wall is present and no adhesions are suspected. But if it is negative, that means it is all stuck together. How do we insert? This is the pouch of Douglas obliteration, which is shown in this case, which is the sliding sign is absent. So what happens is, this is when you are introducing the transvaginal probe. First, you will introduce it. Then you will withdraw it a little bit so that you can see that the rectum posteriorly is moving or not. Just withdraw it and hold there and observe. Being the rectal normal movement, if the rectum is normal and there is no adhesion in this area in the pouch of Douglas, it will show normal peristalsis. And you will see that it is freely gliding. But if there are adhesions, then when you are putting the probe, you will see that this is not moving. It is fixed. So this is a dynamic transvaginal ultrasound, which tells us a lot about the pouch of Douglas obliteration, cul-de-sac obliteration. Now, how do we monitor during ovulation induction? Transvaginal ultrasound is performed to assess the follicular growth, as we have done before, endometrium and uterine arterial blood flow during ovulation induction cycles. We will check the ovulation. We will do the assessment of the follicle. The follicles are measured by taking two orthogonal diameters and then taking the average. If there is asymmetric growth in the follicles more than 15 mm, then you can take 3 measurements also and take the volume. Usually, in such cases, we will take 2 measurements in each follicle and then take out the average. So it is better that when you are doing the ultrasound, save all the images. Label it, save it, that this is first, say you are assessing right ovary, write down right ovary, save all the images. Then go on to the left ovary, save all the images. Take the print, sit down, take out the average of each follicle, and then give the follicular assessment. After that, the endometrial assessment, again, how we have done the thickness, morphology, grading of the vascularity. You will put the power Doppler box. Try to keep the power Doppler box smallest possible so that the time gain compensation happens and you are able to pick up even small amount of blood flow. Dominant follicle versus clear follicular cyst. Most commonly where we get stuck on ultrasound is whether it is a dominant follicle or whether it is a cyst. On an ovulation, ultrasound with color Doppler, a dominant follicle is usually smaller, fluid-filled, has thin-walled, and if you put color flow, it will show a uniform flow around the periphery. A follicular cyst is bigger, it has got minimal internal flow, has anechoic fluid, but the borders are not very well defined. However, when you are practically looking at it, they look the same. So what is important is our size. If you are taking the average, and when I say follicular cyst or dominant follicle size, I am referring to the average of 2 dimensions. If it is exceeding 3 centimeter, the average of 2 dimensions, then we consider this as a follicular cyst. However, if it is less than 20 mm or even up to 24, 25 mm, we consider it as a dominant follicle. So make sure that you are taking 2 dimensions and taking the average. And if it is more than 3 centimeter or 30 millimeters, label it as a follicular cyst and not a dominant follicle. Thank you so much. In case there is anything else that we can, you would like me to discuss or answer your questions, please feel free to write in the box or you can ask me directly. How to assess anterior sliding sign. So when you are assessing the anterior, you want to assess sliding sign. That means that you are suspecting adhesions, you are suspecting a case of endometriosis. So you should, when you are looking, when you are putting in the probe, you will be able to see the movement of the anterior vaginal wall and the adjacent bladder wall. If there are some lesions there, you will not be able to see that. But what you can see is that when you withdraw the probe, you have inserted the probe, the lesions can be effaced, you withdraw it a little bit and keep the bladder slightly full, not over distended. you will be able to see that whether the bladder wall and the anterior wall of the vagina, the vaginal fornix, whether that is freely moving or not. Like you are doing for the posterior vaginal fornix and rectal, you can do for the bladder wall, keeping the bladder slightly full, not over distended. Otherwise, it will oppose and the lesions will be missed and the sliding sign cannot be